You all for joining this special research grand rounds in person and online. I'm John Finkelstein, Senior Associate Dean for Research and Scholarship, and really thrilled to welcome Dr. Daniel Yang from KP, who is the VP for AI and Emerging Technology, and Dr. Gurpreet Dhaliwal, Professor of Medicine at UCSF and a nationally recognized expert on diagnostic reasoning. I want to thank not only our student presenter, M2 Adam Lessing, but two of our faculty who I see here who helped him build up this case, refine the case, Dr. Michelle Rios and Dr. Christine Navarro.
All right. Well, thank you all for being here. I think this should be a lot of fun. Just a little bit of context with this case. Dr. Dhaliwal knows nothing about this case. Dr. Yang has the case in advance just to prepare the prompts for Copilot, but Copilot has not seen this case yet either. And so I'll just present sort of similar to like a small group type of session. We'll go through some of the information in the case, and then we'll pause at various points to hear first from Dr. Dhaliwal and then from the AI tool. So a 22-year-old woman presented to her primary care physician with concerns of diffuse body pain, fatigue, and nausea since placement of a levonorgestrel IUD. Despite removal of the IUD, her symptoms continued, and the patient had several outpatient visits for back pain, left shoulder pain, and right arm pain. The review of systems is negative except for above. The screen revealed no contributory health-related social needs, and the past medical history includes PCOS, incidentally discovered asymptomatic nephrolithiasis, as well as obesity with metabolic syndrome and steatotic liver disease. She doesn't currently take any medications, and physical exam is unremarkable except for tenderness of the right upper arm without point tenderness and a normal neurological exam. Okay. So the first question is, what diagnoses are you considering?
And where else does she have aches besides the right upper arm? Was it diffuse, or was it, you can go back one slide if that's helpful. Back, shoulder, and right arm. Okay, fair enough. So I'll be a little more abbreviated than normal because we have another discussant in the room, which is the computer, but I'll just share my approach that in general in clinical problem solving, it is helpful to peel away the demographic information of the patient at first blush and just focus on the main problem. So the main problem we're solving is sort of you can say diffuse myalgia or diffuse aches or multifocal, whatever adjective you want to put in front of it. And then I will layer in who this person is. I forget the age, I'm sorry,
It's 22.
22. So she's younger. The fact that she has an IUD is something I'll have to grapple with, and that's been removed. I think there's probably no worse preparation from that question than practicing at a VA for the last 25 years, but I will do my best still to see if that is relevant or not. And then I'll go through some of the other things in her background, which just like who she is, what she has will also be relevant. So how do we approach diffuse body aches? In general, clinicians first try to localize it to an organ. If they have an organ that they can pin that ache on, it gives them somewhere to get purchase on. And typically diffuse aches that are in the appendicular skeleton will be related to muscle diseases, bone diseases, or nerve diseases. So you start to think about what are reasons that muscles may ache or myalgias. Those are, just to give broad sweeps, those are things like rheumatologic diseases, or infections sometimes lead to myalgias. What would lead to bones hurting? Bones oftentimes hurt when there's invasive diseases of the bone, or if there's a metabolic abnormality that's weakening their infrastructure, like osteomalacia or osteoporosis, leading to fracture. And then pain that is a diffuse and of neurologic origin oftentimes can either be central in origin, if there's something that, for instance, the thalamus or a central pain processing point, or it might be that there's diffuse polyneuropathy. So just broad, I don't have much more to go on other than to think about, can I localize her disease to one of those areas? And I think that is a reasonable but not cumulative or final starting point. Then I want to layer in who she is because she's on the younger side. Some categories of disease are going to be less likely. For instance, malignancy is at a lower rate than if she was 62 or 82. So I might think that's less likely as a cause for this, but that she's a woman might increase the probability that there's an autoimmune disease in that first category. Those are soft clues right now, but they're things that sort of tip my thinking one way or the other. Then there's the acuity of it. It's been going on for how long? I'm sorry, I should say.
It's been going on for a little while.
Okay.
Don't have.
Okay, I'm just gonna let's just say maybe 2 to 3 weeks, something like that. The other thing to think about is the tempo of illness. Like certain things are self-limited. For instance, many viral syndromes oftentimes peak and then become self-limited over that time frame. In fact, 3 weeks is oftentimes why formal definitions of FUO end with 3 weeks of observation, because that is the tail end of when most self-limited viral infections end. So could have this have been COVID or flu, et cetera, conceivable. Then the part about that's a little bit unusual is that it's patchy. almost all of those things that I mentioned have a diffuse nature to them, and you see there's sort of hot spots in her body. Perhaps this is the advent of a myalgic condition that has focality to it. A common thing would be fibromyalgia, which actually has trigger points and pain points that use, or the phenomenon itself is very localized, like infection has emerged either from the implantation or removal of the IUD, and that is leading to metastatic infectious foci in those spots. And among her past medical history, I think the only thing that gives me a little bit of diagnostic hypotheses is the presence of nephrolithiasis. That's often there's multifactorial, but I'm wondering if there's going to be an underlying explanatory condition like hyperuricemia, which is a little bit young for, or hypercalcemia, which can show up in any age group. So I'm tracking those ideas as a first pass.
All right, let's see what Copilot has to say. So just to give you a little bit of, I've just copy and pasted the case. I've given it some lightweight prompt engineering. So I've asked it to be an expert internal medicine physician solving for a case, and I've given it some instructions on providing a differential diagnosis, as well as some reasoning behind findings that support as well as are inconsistent with that. So let's see, it's thinking.
Okay, Daniel, how important is it that you gave it all that information before you gave it the case?
Well, so I actually took this prompt from a JAMA Network open study we did, which compared physicians with ChatGPT versus physicians with conventional resources. And then there was a third arm, which was AI alone. And I don't know if you're familiar with that study, but the top line results was that AI outperformed both physicians with and without AI. And so this was derived from that prompt. So all we did is we took the clinical case, we added that prompt to the top, and we compared the responses with the physician's response. I've told it to think deeper, so I wonder if that's a mistake. And maybe I should ask it not to think as much, maybe activate system 1 versus system 2. So
off the cuff.
Here we go. Okay, yeah. Okay. So this is it thinking really hard. So we've got fibromyalgia, supporting findings, young woman, diffuse multi-site pain, chronic fatigue, largely normal physical exam, aside from the nonspecific right upper arm tenderness, opposing findings. While they have characteristically tender points on exam, we don't have the specific types of tender points here. Nausea, not a classic symptom of fibromyalgia. We have an autoimmune syndrome. Placement of the IUD raises the possibility of an immune-mediated reaction. We have systemic manifestations, diffuse pain, fatigue, nausea are features that could be seen with a dysregulated immune response. Opposing findings, persistence of the symptoms after removal of the IUD makes a direct local reaction less likely. I'm not sure about this ASIA. That's a new acronym for me, but I guess it's controversial. And third, we just have this catch-all, somatic symptom disorder. So support the consideration of a centrally mediated pain disorder as opposed to a localized organic process. Here are some additional diagnostic steps: CBC, metabolic panel, LFTs, thyroid function, inflammatory markers, autoimmune panel. And get more history. Maybe consider talking to a specialist, such as a rheumatologist.
Very good. I'll just quick reactions to it. I'm glad it endorsed fibromyalgia. It's nice to see you're on track. It reminded me of a dissenting information, which I think is important. I lost track that she had nausea. Nausea oftentimes is a clue if that was correct and it didn't hallucinate it. Did they have nausea?
Did they have nausea?
Yes.
If she did, then that is worth tracking, because some of the systemic disorders I mentioned are more likely than fibromyalgia. So I appreciated that. I too have never heard of the ASIA syndrome, but I appreciated that it gave me a hypothesis, which is many other examples in medicine where we implant a foreign body and people have a allergic reaction to that. That can happen with valves and joints, etc. So even though I've never heard of it, it made me think pathophysiologically about that possibility. And then medically unexplained syndromes, it's right to mention because that has a huge amount of practice, but appropriately put it at the bottom of the list. That's something that you have to earn that diagnosis, meaning the doctor has to work their way to it. So I appreciate it. I think it also couldn't go any deeper than that, and I think that's reasonable given the data we have.
Yeah. All right. Well, thank you. Thank you both. We'll move on to the next bit of information. So there's a follow-up visit. So after continued right arm pain, the patient returns to the primary care setting and was then referred to the emergency room for further workup. So there's an X-ray. There's a 2.7 by 3.6 centimeter lucent lesion in the distal right humerus with no cortical disruption. There's an image of the X-ray there. There's also some initial labs. So we have a CBC, electrolytes, and blood sugar that are all normal. Liver function is AST at 62, ALT is 87, and alk phos is 1650 with albumin of 4.5. And the calcium is 13.3. Okay. She's admitted to the hospital for further workup. And our question here is, what further studies would you like to obtain at this point?
Okay, perfect. Just recapping, remember that the first goal in diffuse myalgia or diffuse aches is to localize it to an organ. I said typically it's neurologic, muscular, or bone. I think now we have strong signal that it's bone. I just want to say it's not 100% bone because hypercalcemia can also cause the muscle aches. But I think we now know the center of gravity is in bone disease. And there's two parallel tasks to figure out, which is what is the cause of that bone lesion and what is the relationship to hypercalcemia. It may not be as immediately obvious as you think. They both deserve an orderly approach. So when we have lytic lesions in the bone, doctors usually think of cancers right away, but there are other things that can do it, and it's just worth being systematic about it, which is there can be cancers that are both primary, like osteosarcoma, and metastatic, of which there are many. We tend to learn a lot of acronyms, but they just reflect the general prevalence of common conditions. She's 22, so we have to think about what cancers might happen in a 22-year-old woman that would also have a tendency to go to bone. And I must say it's a relatively uncommon presentation regardless. Could it be something that is much more common in elderly patients or older patients, like lung cancer or skin cancer that has metastasized, or something that equally affects young people like a lymphoma that's there? I am thinking though about her possibly having a primary bone carcinoma. There are infectious diseases that cause lytic lesions. We don't think about it much, but one of the most common ones is in California, which is cocci. It tends to cause its lytic lesions much more commonly in the spine than it does in the appendicular skeleton, but we have to think about infections as sources of lytic lesions. And then occasionally, profound metabolic conditions cause lytic lesions. A great example would be is it telling me? I don't know if it's giving me a clue or not. It's sort of like, don't go there. But just to complete the thinking, is there are metabolic conditions when they're left unchecked for a long period of time, like primary hyperparathyroidism, if it's unchecked for long periods, can create things like brown tumors. So even though we think of cancers that are primary, like osteosarcoma, think of metastatic cancers like multiple myeloma or sarcomas and lymphomas, we think about metabolic bone diseases. I think our greatest concern is then to figure out, and that alk phos, by the way, of 1650 reflects the destruction that's likely happening in her bone. We still owe it to her to follow an orderly approach to hypercalcemia, which is measuring PTH, which likely is going to be suppressed in most of the scenarios I mentioned, but elevated in one, which is the hyperparathyroidism, vitamin D levels, and elsewise. But now we have a center of gravity of the case, and we say probably her other diffuse aches are centered on bone lesions as well.
So in terms of specific further studies,
the calcium workup will be done with this set of tests. You'll get PTH, vitamin D, 125 vitamin D, and SPEP light chains if you like to be thorough. Some people will start at a more constrained approach. And then in terms of imaging, now we really need to image all the spots where she hurts to confirm if there aren't bone lesions there. But then it's optional whether you start biopsying those sites or whether you look for a primary through scanning, which can be the CT scan if exam is not revealing. And I just want to remember her age of 22 is probably what makes this the greatest challenge to envision what, if a malignant disease is there, what malignancy would be doing this. And it's equally important what things I'm not analyzing. I'm not analyzing the liver function test because we have a satisfactory explanation for them before, which is that there is fatty liver, and also because they are mild. Doctors tend to know that severe things like that calcium and alk phos must be explained, whereas the AST, ALT need not be explained necessarily because they are mild and compatible with an existing diagnosis. And then while Daniel's working, I'll just reemphasize one of the things I did that was speculative and paid off, but most of the time would be guessing, could kidney stones lead to be a reflection of hypercalcemia? For the vast majority of patients, that would have been speculation that would have been refuted. But every once in a while in mystery cases, we throw out hypotheses to see if there's that was a clue. The present that she had nephrolithiasis in the past maybe gives us a clue that this hypercalcemia has been longer lasting way before even this diffuse ache she's had for the weeks we're dealing with. I could open up to the room if people have questions or hypotheses while we're getting the computer to work, other things they might cross their mind. Yes, right there. Yeah, I have it. I'm not sure that that's going to be causal or not. I would have because they said the complications that I'm aware of are the hormonal changes that happen and mechanical changes that happen with insertion. I know less about complications that might happen with withdrawal. If something was left behind and that allergic hypothesis was there, I can't map an allergic reaction to a lytic bone lesion. So I hope it's not out of cognitive convenience, but I've sort of moved that to the side and it's been like it's true, and unrelated rather than it's a causal link. I may learn something otherwise. For instance, just as a side thing, maybe the IUD caused a granulomatous reaction and the granulomatous reaction caused hypercalcemia. That would have been wonderfully elegant if she didn't have bone lesions to explain, but that doesn't seem the case.
All right. Well, I was trying to put the image in to just see if Copilot can interpret it, but wasn't letting me copy it in. So instead, I just put the information that we have here and asked it to give a revised differential diagnosis. So again, it picked up on the bone pathology, potentially linked to metabolic or neoplastic process. Its revised differential diagnosis is putting a primary bone tumor, number 1, that again, supporting findings is the lytic lesion in the humerus. The absence of cortical disruption suggests a slow-growing process. Further imaging is required. The young age of the patient aligns with common benign bone tumors, such as giant cell tumors or aneurysmal bone cysts. Opposing findings, the hypercalcemia is atypical, suggesting a potential systemic process. No pathologic fractures or periosteal reactions. Number 2, metastatic bone disease. Parathyroid carcinoma, breast cancer, multiple myeloma. Again, the hypercalcemia, suspicion for a paraneoplastic syndrome, elevated alk phos, bone tumor, possible marker of bone metastasis, history of metabolic syndrome, and steatotic liver disease. I don't know if that's true. It may have hallucinated that. Does not directly dispose her to malignancy. No primary malignancy is an opposing finding. The X-ray lesion lacks aggressive features. And lastly, it has hyperparathyroidism, either primary or paraneoplastic. The supporting findings are the hypercalcemia, bone involvement in hyperparathyroidism, which can cause lucent bone lesions that mimic benign tumors, elevated alk phos. And in terms of opposing findings, no reported renal dysfunction, no prior diagnosis of a parathyroid adenoma or carcinoma, and more imaging, MRI, bone scan, PTH levels, vitamin D, SPEP, UPEP, some tumor markers, and consideration of a bone biopsy.
I'll just remark, I think this is very, very helpful. It sort of systematically went through some of the things that we mentioned, right? The brown tumor called the osteitis fibrosa cystica to remind us of that. But I also really want to point out here the educational part of this. When sometimes people ask, like, what's a marker of great reasoning? It actually departs from what we do in medicine, which is like, tell me what you think is going on. That is rarely a marker of a great reasoner. Great reasoners in the intellectual sense are more like barristers or lawyers. They're able to argue pros and cons and in a very convincing way. I mean, if you really want to say, is someone a great reasoner about a social issue, a cultural issue, a medical issue? It is not that they make a case for something, is that they're so adroit that they know the pros and cons. And that's a great, so to the extent I'm trying to do that, you can see that this is a great adjunct, whether you're the student trying to learn or the teacher trying to up their game. And for the most part, I agree. Like it said, not a truism, but it is true. It's really rare that primary bone cancers cause super high hypercalcemia. And I should emphasize, this is a very high degree of hypercalcemia. It noted that she doesn't have renal dysfunction, but she has an albumin of 4.5, which is relatively unusual and tells you that she's probably mildly dehydrated by the hypercalcemia, which induces diabetes insipidus, which makes people hypovolemic. So although its inference it made is correct, there was no AKI told to us. I bet you she's a bit volume down. I think it got to the same place. Daniel, I just want to scan real quick and then we'll go to the next one. If there's anything else, it gave me, I don't know a long list of primary bone tumors because I'm in the business much more metastatic bone tumors with the age group I deal with. So it's helpful to have a reminder of this entity like a giant cell tumor and the aneurysmal bone cyst, the latter one, which I don't think is relevant. And then there's teaching points if it's correct. Now I'd have to verify this. I wouldn't take it lock, stock, and barrel. But if it tells me, hey, the absence of cortical destruction tells you that it's slow going, I might internalize that and say, like, note to self, I don't think I knew that very well. So I either have to fact check that somewhere else or run it by a radiologist or an oncologist. But it's something I'm like, there's the learning edge for me on the case. So again, I think we have an approach to a lytic lesion we would be doing with or without hypercalcemia. And we have an approach to hypercalcemia that we would be doing with or without a lytic lesion. So this is thinking in parallel the way I think a clinician would be as well. We want to bring them together, but it's likely that the cancer has to be the driver of the hypercalcemia for them to elegantly do that, or uncontrolled hyperparathyroidism. Those would be two ways that it might unfold.
All right, so let's see how it unfolds. We have, the hospital admission and, both of the studies that the AI and that Dr. Dhaliwal requested, we have some of that information. So we do have some additional imaging. So the CT, chest, abdomen, and pelvis with contrast shows expansile bony lesions in the left first rib that measures 2.2 centimeters, the left anterior third rib measuring 2.2 centimeters, the right seventh rib measuring 2 centimeters, and the right fifth rib. Additional expansile soft tissue lesions in the sacrum measuring 4.6 centimeters and a 1.7 centimeter lytic lesion in the right iliac bone. So does this impact your leading diagnosis now? And the additional lab question, we do have those results on the next slide for those labs that you previously.
So I think that just to be brief, I think all I'll say is the extent now, first of all, the diffuse pain is well explained. It's situated in bone disease. And the extent of it is more characteristic of malignancy over metabolic hyperparathyroidism, but not completely so, and very unusual for an infection to do this much, like the Cox example I gave, unless the person really was infectious in many other ways. There's been no fever, no exposure that we know of in terms of travel around California or otherwise. So I think I'm leaning more towards malignancy. One thing that gives me a little bit of pause is, if I remember correctly, there's been no weight loss or none reported. Is that right?
Unreported.
And with this burden of cancer, it's a bit unusual. And now the other thing that's a bit curious is chest, abdomen, pelvis hasn't found the primary lesion. Not that it's perfect. There are things like mammograms and colonoscopies and PET scans that are done, even when a full CT scan doesn't show. But the absence of an obvious primary, like a young person with a genetically driven lung cancer or a lymphoma that's present in all of the stations of the mediastinum or the abdomen, is a little bit of an unusual situation. And it makes me think that maybe the answer is figuring out the cause of hypercalcemia and then working backwards and say, are the bone diseases compatible with it or not? So I'm having a hard time conjuring up the occult cancer that's landing in her bone in multiple spots. Multiple myeloma might be one that does that, but boy, is her age a major outlier for that. Or is it some unchecked metabolic bone disease, hyperparathyroidism? But even there, I will say, when people have osteitis, fibrosis, cystica, it oftentimes is not this diffuse. This degree of bone disease is oftentimes one or two bone tumors is giving me some pause. But I would still proceed orderly and sort of shift my direction. I mean, there's an interest in biopsying those lesions. I think now that we struck out in other ways, we have to do that. But I think the hypercalcemia workup, and particularly PTH, and I will say 125 vitamin D is of interest. And the reason that's of interest among all the other things and the SPEP is that those give clues to specific cancers. So the SPEP would elevate multiple myeloma or a lymphoma, and a 125 elevation in vitamin D would be very characteristic of lymphomas. All the other cancers don't do that as reliably as lymphomas with their granulomatous histology. So that's the space I'm in now.
With Copilot things. So they are emphasizing multiple myeloma or a similar plasma cell dyscrasia with the presence of multiple lytic lesions, profound hypercalcemia, elevated ALK phos, no reported anemia or renal failure, no mention of monoclonal protein. They don't talk about age here, which you did, Gurpreet. Number two, metastatic cancer. The multi-state bone lesions strongly favor a metastatic process. Hypercalcemia can be associated with paraneoplastic syndromes, such as a squamous cell lung cancer, breast cancer, or renal cell carcinoma. And a large sacral region raises concern for metastatic spread from primary tumors. Opposing findings, no visceral organs noted involvement, no previously identified primary malignancy. And third, the primary bone tumor. Multifocal involvement is less common, more characteristic of metastatic disease, and no evidence of an aggressive periosteal reaction. So again, bone marrow biopsy, SPEP, UPEP, PTH, PTHRP levels, and a CT chest with a whole body PET scan, as well as a bone biopsy of one of those regions.
And I'll say that one thing that crossed my mind, which just emphasized, is perhaps the sacrum is ground zero. I'm trying to think, where is the primary? And if it is, it may be a primary bone tumor, osteosarcoma, for instance. It may be a sarcoma of some other variety that has arisen near the bone, but to us it appears osseous. And that is what's metastatic to all of those sites. Or it could be, you have to hold these different formulations in mind. I think if I go through that, everything it said, I agree with. And we find ourselves, well, oftentimes you want to make a case for something is when the pros are very strong and there's very weak cons, but there's really good counter arguments into all of these. This is actually a marvelous picture for multiple myeloma. It is just that age, that is it, that is the thing. But there's also no renal failure and there's no anemia. And you start to say, can you really make a case for a plasma cell dyscrasia doing that one thing in excess, destroying multiple sites of bone and invading multiple sites of bones and leaving the rest of its profile untouched? And so while I got to say the picture radiographically and clinically looks like what a cancer would do, and myeloma being a good one, the possibility that there's just unchecked hyperparathyroidism still looms in my mind. And one other thing, ALK phos elevation is not typical of multiple myeloma. It is dominantly an osteoclastic phenomenon in the bones. So it's very rare for multiple myeloma to have anything other than a modest rise in the ALK phos. And her ALK phos is sky high. It is through the roof, signifying that there's just a lot of osteoblastic activity that's occurring in concert with the osteoclasts. And so I'm still at a bit of a dilemma about metastatic cancer versus a metabolic bone disease, but that is my reasoning behind it. And the computer, if anything, is just sort of helped me understand that this dilemma is legit. Like, I'm not way off. There's reasons to be on both sides of the equation. And as I said before, at the outset, I don't bring her demographics into it, but as I go more and more into the case, I'm saying what could be happening in a 22-year-old woman.
All right. So we do have some more of those studies that should give a little bit of additional context on what we're looking at. So the monoclonal proteins and free light chains are all normal. Okay. The additional laboratory studies, parathyroid hormone is elevated at 1,165. PTHRP is normal. Phosphorus is low at 1.8. And now the question is, what's
fair enough. So this is actually not the final diagnosis. We're in the ballpark. I think what it allows us to do is relinquish the malignancy hypothesis writ large and reject the myeloma hypothesis in particular, because the SPEP and serum free light chains reduces it to almost just 1% probability of what's called an isolated plasmacytoma. But for all practical purposes, with her age, that now hypothesis is rejected. Hyperparathyroidism is supported by this diagnosis, and the only twist on it is that parathyroid hormone level is through the roof and the degree of bone disease is incredibly aggressive. So in there's two formulations that I'm wondering, which is, yes, her parathyroid glands are responsible for this picture, the disease in the bone, the calcium that's been leached from it, the phosphorus that's been dumped through the kidney. All of those things are true. What I don't know is what's the nature of the parathyroid disease. Is it a hyperplasia, an adenoma? Those are sort of the moderately overactive forms that lead to typical parathyroid excess. Or is it the rare but super aggressive, which is the adjective I put on this, parathyroid carcinoma? And I have to say, just thinking through the spectrum, I'm drawing on the library of the many hyperparathyroidism cases I've seen over the years. I have very few that have a recollection of this height and this degree of aggressiveness. And on that one fact alone, even though I can't draw on a large experience of parathyroid carcinoma, I might worry more that she does actually have a cancer, but it's arising from the parathyroid gland. It is possible that this has been the other two versions that have been checked for unchecked for a long period of time, but that would be my concern here.
All right.
All right, great.
This is where I'd love to see what the computer does with those numbers, because it should be in the same ballpark that we are in here.
Oh, wait, sorry. Let me update.
Anyone have any comments on these numbers, having seen some of these conditions, people's experience with hyperparathyroidism primary, that is? It shows you oftentimes that medical knowledge is just this branching ontology. It's just, okay, now I know hypercalcemia. Okay, now I know I'm at the parathyroid gland. Okay, now I have to figure out what the source is, right? It's just this endless branching network. And the bone disease and the height of the parathyroidism, I think you have to balance a common disease being atypical versus the rare one I'm worried about, which is parathyroid carcinoma.
All right. Oh, Copilot has put its dollar on.
All right, very good.
Primary hyperparathyroidism due to parathyroid carcinoma. The severely elevated PTH, while benign parathyroid adenomas are the most common cause of primary hyperparathyroidism, levels exceeding 1,000 raise suspicion for the carcinoma. Profound hypercalcemia, which aligns with primary hyperparathyroidism. PTHRP less than 5 rules out paraneoplastic hypercalcemia. Low phosphorus, consistent with PTH-driven phosphaturia. Expansile lytic bone lesions suggestive of osteotitis, fibrosis cystica, the skeletal manifestation of severe prolonged hyperparathyroidism, often mistaken for metastatic bone disease. And why parathyroid carcinoma over adenoma? It kind of summarizes severe hypercalcemia, although I don't think it was above 14, multi-site bone involvement, and extremely high PTH levels. So here it would look for neck imaging, surgical consultation, and further staging workup, including genetic testing.
Look a little bit more at the wrap up here. So they did do a biopsy. So the prominent population of the multinucleated osteoclast-like giant cells scattered within collagenous stroma with intervening cellular areas of proliferating stromal cells showing similar nuclei, and nuclear atypia is minimal to absent with scattered mitoses, and atypical mitotic features are not identified. So this also supports that thinking. The final diagnosis, so it is osteitis fibrosa cystica. The patient was treated for the hypercalcemia with IV fluids, furosemide, and zoledronic acid. Scans showed a left inferior parathyroid adenoma, and the patient later underwent surgical parathyroidectomy, and later imaging studies showed regression of the cystic lesions in the bones with significant improvement on pain. So discussion, I think this has come up both in the co-pilot's reasoning and certainly in what you've shared as well. The osteitis fibrosa cystica, it's a manifestation of both primary and secondary hyperparathyroidism. It can be confused with giant cell tumors, which is primary tumor of the bone, and the misdiagnosis could occur if hyperparathyroidism is not identified. It's greater frequency in primary than in secondary hyperparathyroidism, and the common sites of involvement include the mandible, the clavicle, ribs, and the pelvis. So the treatment is by managing the underlying hyperparathyroidism. So in this case, that's surgical parathyroidectomy.
And just to be clear, then the final diagnosis was it was a parathyroid adenoma. It was not a carcinoma.
It was a parathyroid adenoma.
And the two scenarios we mentioned was that either it's just been unchecked for so long that it wrecked bone in many, many spots, or it was aggressive not because of time, but because of the disease itself. So I think that one point to raise is it probably shows the underlying adage, which is a rare manifestation of a common disease, still reigns more common than the textbook manifestation of the rare disease, which would have been parathyroid carcinoma. And I guess to some degree, both me and the AI, perhaps a little bit because of the circumstances, but I also think on sound grounds, those sort of very notable findings sort of leaned in that direction. But it shows you in the end, it is still a probabilistic enterprise, right? And so getting in the ballpark sometimes is the best that either the human brain or the computer brain can do. And then we take it from there.
Thank you. Thank you both.
Thanks. Thank you, Adam. That was really, really fun and amazing. We're going to now just have this is a Stephen Colbert moment. We're going to have our guests and we're just going to talk about it a little bit and take your questions. Okay, so let me just start with a couple of questions. So Dr. Dhaliwal, and if anyone you want to do something fun, Google the New York Times article about Dr. Dhaliwal from about 15 years ago. It's really fun. You've been doing this kind of thing for 15 years. So how is this different? How have you seen it change?
Yeah, you mean having the AI with me in the room?
Yeah.
Yeah, I think it was sort of, it was both informative. So there's moments where it reminded me of something like, hey, keep track of the nausea. There was times when it was reaffirming, like, hey, the likelihood of the IUD being responsible is, low, et cetera, but do keep track of it. Or even at the end where it's like, hey, doc, I agree with you. Like, I think this is, even though we were sort of ultimately in the very final formulation, not correct together, it gave me some reassurance that the line of thinking was very logical, right? And so I think this product is aptly named Copilot, but I felt like I had that, and you kind of appreciate that.
So just let me say, in just watching you were not. It appeared you were not threatened at all by having the partner. You're a confident diagnostician, and you weren't threatened at all by having this partner. And Dr. Yang, you've kind of watched the arc of AI and have thought a lot about the future of AI and diagnosis. Kind of, what does it say to you?
Well, I mean, one, I'm sure that the products that they were testing against Dr. Dhaliwal 15 years ago were not nearly as good as what we're seeing today. So, I mean, those were very probably expert systems where we would encode if-then statements. They work well in very specific environments, but they're brittle. They don't adjust to new findings or unusual findings. They can't explain their reasoning. And so one, I think what we're seeing here has been an evolution of very rapid technological innovation. But two, I mean, this is what I learned from Dr. Dhaliwal when I was a resident is intellectual humility. So when I was a resident, he was one of the most avid users of traditional clinical decision support tools, things like Isabel, Visual DX, that would provide a differential diagnosis. And I think that's quite rare and unique. It's actually probably one of the drivers of its diagnostic excellence, is that most providers, they kind of think they know the diagnosis and they move forward without any assistance. And so the act of really checking your own reasoning with external guidance, whether that's with a peer or technology decision support, is actually unusual, because most doctors, I feel like, don't normally seek this extra guidance unless they feel they need it.
So we really do want to open it up. So let's start in the room, and Dolores will help me for people online. Who's got a question for our guests? Oh, let me start up here with one of our students.
Hi, thank you for talking to us today. My name is Bakal. I'm an M1. I was curious about, so I feel like we hear a lot of jokes about like patients or patients' partners being Dr. Google, like Googling their symptoms and coming in convinced that they have some super rare disease. Are you seeing nowadays in your clinic more like Dr. ChatGPTs? And are patients more accurate nowadays with the diseases they think they might have?
We talked a little, we had really great discussions this morning, just sort of the general trend in society to DIY, right? Do it yourself. And so, right, there used to be magazines and books, and then there was, online CD-ROMs, and then people could check Google, which made it much more accessible. And now they can do a ChatGPT. I haven't found it to be that radically different. That is to say, first of all, I think only a minority of patients, even though sometimes they weigh on docs' minds, only a minority of patients really come to sort of a preformed, like, I've analyzed my case and I'd like your reaction to it. I do think what you find is many more people have done it if you ask them. So what I oftentimes learn, because sometimes you learn in primary care or in urgent care to do this thing as you approach a problem, which is ICE. It's a great mnemonic. It's very practical, which is you as the doctor have to figure out what's the issue, what's their concern, and what's their expectation. It may not be what you want to hear, but you just have to get those out there. So what is the issue? I have a sore throat. What is my concern? My concern is I have strep. What is my expectation? My expectation is you will write me a prescription for antibiotics, right? It doesn't mean you have to do any of those things. You may find the issue is slightly different. Their concern is not your concern, but you now know what you have to address, and you don't have to meet their expectation, but you do have to address it. And knowing that they looked up something and they found it is no different than any of the other inputs that they might have had. Like, my neighbor told me to ask you about this, or my mother once had that. And so it's just another way of finding out what's on their mind. So I think maybe we'll see more of it. Maybe Daniel can add that perspective on trends.
Well, first of all, actually, one of the clinical pearls I learned was ICE. And I'll give you an actual example. We were seeing a patient together in the ER that was had a long-standing dry cough and was very adamant about getting a chest X-ray. And no amount of reasoning or convincing, or I don't see any red flag symptoms, would convince him otherwise. And I remember running the case by Dr. Dhaliwal, and he explained the whole ICE, and he said, well, we have to understand what the patient expects, the E. And when we went back in the room, he was worried about lung cancer because his father died of lung cancer. So unless we address that specific need, we were not going to satisfy this patient. And so once we understood what that was, we could then speak to that issue. But on the question of Dr. Google versus Dr. ChatGPT, one, our patients are using it. We're probably using it as well, right? So I think we just need to be honest with that fact. I actually think it's a huge step up from Google. And I was describing in a prior conversation, I was actually on a panel with the chief science officer of Microsoft right when GPT-4 came out. And at Microsoft Research, they've done a lot of research on how people interact with internet search, right? Microsoft has Bing, which is the second largest search engine in the world. And what they found was that the way that these search engines are engineered is they're optimized to identify the link that you're most likely to click on. And they want to move that link up as far as possible. And so what it leads to with a lot of these, searching of symptoms is more a reflection of psychology than epidemiology. So if you were to type in muscle fasciculations into Google or into Bing, one of the first results will be ALS. Now, it's not because ALS is the most common cause of muscle fasciculation. It's because that's what people are most worried about when they're searching for muscle fasciculation. But when you type in muscle fasciculation in ChatGPT or Copilot Chat, you'll get a much more nuanced, kind of almost epidemiologic description of muscle fasciculations are typically benign. They're caused by a host of issues, including metabolic abnormalities. And then at the bottom, they do provide some more serious neurologic issues. And so I actually think as a patient, that is much more useful to have that broader contextual understanding. two, the way that we interact with these searches is we don't put a lot of the demographic information or contextual information that as clinicians are incredibly useful. And when we use Google search, we'll just ask a question like, what is the cause of muscle fasciculations? You wouldn't put an entire clinical scenario where you'd put your age, your past medical history, your other symptoms, and you can essentially do that. You can copy an entire note and put it into there. And so again, it gives the AI a lot more to chew on, which I think, again, when you do that, which we did here, it provides much more relevant and perhaps even more accurate information. So there's a whole patient community that's supporting patients in how to better leverage these tools to not only help with their diagnostic odysseys, but also to help explain what's happening in the medical system, right? So when you include open notes, which are patients able to access their own notes, they are absolutely putting their notes into ChatGPT and asking to explain what the heck the doctor was trying to say. What are these next steps? What do these lab values mean? So I think by and large, it's a net positive.
So any questions from online? Let's try that.
The question is, what role do you think AI should play in how we teach clinical reasoning to students and residents?
I think that there's an infinite number of things that can be done. I will underscore what I think the hallmark of reasoning is, which is the ability to give strong arguments. In some ways, when I'm a teacher, I'm almost more like a law professor or like a rhetoric professor. I was like, I need to know the strengths of your pros and cons. I can reverse engineer everything else. How much evidence-based medicine you know, how much medical knowledge you have. As long as I can see your arguments, I can work backwards. But we all don't have enough time to evaluate every argument that is put forth. I think this thrombocytopenia is ITP. I think this jaundice is just related to Gilbert's syndrome. Those statements are oftentimes advanced by learners in their comments or particularly in their notes, and we don't have time to give them the really great positive feedback. So my first priority would be to give feedback on arguments that are advanced by learners, because that's how we would start modifying their sort of argument, which makes them go back and modify the knowledge that underlies that argument. There's many other things that can be done.
Let's fit in one more question, because there was one question down here from the beginning.
Thanks a lot, Dr. Dhaliwal. I'm Shannon Peter. I'm assistant clinical professor here of internal medicine, and I noticed that you a couple times, you pointed out features of the presentation, and then backed out to features of the demographic of the person presenting. But then a couple of times during your presentation, you also kind of pointed out features of your own training and things that might become more salient or less so based on what you've been exposed to 25 years at the VA.
Yeah.
And, kind of at some point you mentioned the population that you've been used to treating is much older than this patient, and kind of used it as a trigger to remember about some of these primary bone tumors that happen in younger patients that we don't see as much as internists. So I was just wondering, for this community of learners, like how you would, I guess, encourage or how you would frame the importance of kind of bringing their own kind of experience or lack thereof in certain regards of a case into the picture, and like what you would kind of, that step, I haven't seen someone outwardly say it before, but I think it's so important and it goes unsaid. And I just want to thank you for that and just see what your thoughts are.
So thank you for highlighting that. I think whether it's a subconscious influence, what have I seen, right? We start in school up learning rules, but then the experience that we have, our training and beyond, really is the dominant force, right? But it inevitably leads to blind spots. So in the VA, there are certain things you cannot have. I'll just give you an example of the VA. It's an amazing system, and we train over 50% of the health professionals, but there are things about the VA population that actually are filters on it that you may not know, like you have to speak English to get into the military. So for the most part, there's limited use of non-English speakers, or there's certain diseases that are disqualifying for the military, or the percentage of women is 10% compared to 90%, or in the inpatient setting, it's dominantly more men than in the outpatient setting, where it's starting to become equitable or equal with more with the new generation of soldiers and sailors, etc. All to say, if I worked in some other setting, there would also be an unbeknownst to me. Those ones are very obvious because it's known at the VA. If I go to the hospital across the street, there's just a different set of filters that I may not be cognizant of, like insurance status or part of this HMO, et cetera. And I guess one way I think about it, I appreciate you highlighting that I brought it out consciously. But one of the things a computer might do on the side is it doesn't have any of those filters if it's drawing on, the entirety of medical knowledge, right? So as I said, I admitted I don't see many primary bone tumors because I deal with older patients. And so this was a great way to fill in the gap. And I appreciated that moment.
I mean, I think it's one of the reasons why we've seen such a rapid advancements in technology, right? So in 25 years, I'm sure Dr. Dhaliwal has gone from being an excellent clinician to an even better one. But in 25 years, I mean, the number of cases that these AI algorithms have looked at far exceed many, many lifetimes of what an individual can see.
Yeah.
And there's a randomness as well to our clinical training. It's just what you happen to see, when you're on service and who you get slotted with in terms of patients. And so there are just clear blind spots where there's a lot of diseases. I've never seen this condition in my 3 years of training. And so I do think that's another advantage, is the ability for these algorithms to train across many diseases very quickly. And so instead of relying on memory, which I think is highly variable, it actually relies on a much deeper kind of well of experience.
Yeah. I wonder, Stanford trained a skin cancer algorithm to sort of essentially figure out melanoma versus nevi a number of years ago. And, in very short order, I think it took 3 months to match, just match the performance of a panel of board certified dermatologists, right? But those dermatologists have trained for years, college, med school, residency, fellowships, 10 to 20 years in practice. And then they retire, and we start the process all over again with a brand new dermatologist. The AI system that they had created, this was years ago, just took 3 months to train, and they'll just start getting better and better and better. And so for that yes, no answer, cancer or not, it's just going to keep getting better.
So sadly, our time is, I think we have to wind this up because students have to be back in class in a few minutes. Thank you for all engaging. Thank you to everyone online who engaged. Thank you especially to our two guests. This was designed not as like a party trick, right?
No, it's not.
Right? See who could beat who. So I thank them both for engaging in it, but their thoughtfulness around the context and as a moment to think about how we think was just remarkable. And thank you for coming to visit us here. So thank you.
Thank you. It was our honor. Thank you so much.